Well, it's 7 o'clock on the dot here, so we'll go ahead and get started. Welcome, everybody, to CRS Virtual Education. In conjunction with ASCRS Young Surgeons Committee, tonight we will be doing mock oral boards without further ado. So we'll go ahead and get started to keep things going on time. But first, a brief introduction for our examiners. First up, we have Dr. Cusick, who completed her undergraduate degree at Georgia Institute of Technology and medical school at Morehouse School of Medicine, residency at UAB Birmingham, and a master's in public health during her training. She finished out her training at University of Texas Health Science Center in Houston for her colorectal fellowship and is in faculty at Houston. So she'll be doing our first exam this evening and getting started with, let's see, my pairings here are with Dr. Kadigatla. So take it away, you've got 23 minutes.
All right. So you are called to see an inpatient on the medicine service. She's a 27-year-old woman with a history of Crohn's disease that has had on again, off again exacerbations, but she's admitted as of yesterday with an acute exacerbation of her Crohn's disease. She's been admitted to the hospitalist. GI hasn't quite seen her yet, but she has started steroids. They started her on Solumedrol, 40 milligrams IV daily. She was diagnosed with her Crohn's disease about a year ago. She's been on and off again taking mesalamine, but not very consistently. She has seen her primary care and urgent care several times since she was diagnosed and just given steroids on and off. She was admitted yesterday and she had some low-grade fevers, about 100. She had some leukocytosis with a white count of 15 when she came in, some nausea, emesis, some abdominal pain, cramping. That's over the last 4 weeks has gotten a bit worse. Nothing that is, excruciating, but it's just kind of been building to the point where she's not been eating very much. And over the last 6 months or so has had about a 15-pound weight loss. Since she was admitted, or since she was seen in the ER and admitted yesterday, she had an NG tube placed and she feels a little bit better with that, but she's had about 1,500 to 2,000 out of her NG tube since it was placed about 24 hours ago. So you're on your way to see her.
Okay, thank you so much. First thing I'll do is I'll go see the patient and talk to the patient. I'll also ask her about, any prior surgical history.
She's never had any surgery. When you're going down to see her, you go down, you look at her vital signs. She is mildly tachycardic with a heart rate of 105. She's her blood pressure is stable at 120s over 75. Her respiratory rate is 15. She is sitting comfortably on room air. In review, you also see and evaluate her labs from her leukocytosis of 15 when she came in. Repeats shows a white blood cell count of 13, hemoglobin of 8, creatinine is 0.7, and albumin of 2.4. Her CRP is around 100, or is 100, excuse me. And in regards to surgical history, she's never had any abdominal surgery. She's had tonsil surgery when she was a child. She did have a colonoscopy, and that was at the time of her Crohn's diagnosis. And at that point, there was some inflammation within the terminal ileum.
Okay, so I think I have pretty much most of the history that I would like. So I'd go ahead and do an abdominal physical exam, focusing on an abdominal exam.
Yeah, so she's mildly distended. She's somewhat tender, but she reports it's much better since yesterday after the NG tube was placed.
Okay, so I will also go ahead and, if it hasn't already been done so, I'd also go ahead and order a CT of the abdomen and pelvis with IV contrast.
Okay, so you do a CT scan of the abdomen and pelvis with IV contrast. There's noted to be some thickening of the small bowel into the terminal ileum, and there's small bowel dilation through the entirety of the abdomen. The colon is generally decompressed. There is an NG tube in place. There's normal kidneys, no concern for air in the bladder, no evidence of air in the vagina or the bladder. The liver is normal.
Okay, so in terms of moving forward, I'll counsel the patient on what has happened so far and what's her likely course moving forward. Either she responds to medical therapy and we can avoid surgery, or given her history, I am concerned that she may end up needing an operative treatment in this admission. But as of now, there is nothing emergent pushing me to take her to the operating room. So I will start her on total parenteral nutrition, given her malnourishment. And I'll also continue to monitor her with serial abdominal exams. And then I'll also make sure that GI also sees her and sees if there's any other input that they can also provide.
Okay. So she continues on her Solumedrol. She starts PPN, transition to TPN after a couple of days. You're 4 days in, no change.
Okay. So since we're, sorry, go ahead.
Excuse me. NG tube is still between 1,500 and 2,000. She's not complaining of any more pain. She's walking like it's going out of style. She's doing everything that she's supposed to do. But in general, she says no gas, no bowel movement. She's status quo for the last 4 days.
So I'm worried that she's not responding to medical management with her Crohn's stricture. So I will counsel the patient that she'll likely need we should plan for an operative intervention in the form of ileocolic resection with an end ileostomy. In preparation for surgery, I'll also order a CT enterography or MR enterography, whatever is available at my institution.
Okay. So you go ahead and order the CT enterography, and they do the CT. No significant findings other than this small bowel is significantly distended. She vomits around her NG tube 3 times after having to drink the contrast load. When they put it back to suction, they get all the contrast back out. There's still small bowel distension, significant thickening within the terminal ileum. There is no significant stool burden within the colon.
Okay, so I'll go ahead take her to the operating room for a laparoscopic ileocolic resection. If urology is available, I'll also have them place ureteral stents, at least on the right side.
Her last words to you before she rolls back to the operating room is, "Please don't give me an ostomy."
So I will talk to her, and like I said, I'll counsel her, saying that because of her chronic steroid use or her nutrition status, that I would definitely have to give her an ostomy because of the high complication risk of a leak. I'll also mark her for an ostomy as well. I'll also have her meet with the ostomy team so that she can also get some preoperative counseling on a stoma.
Okay. So when do you want to take her to the operating room?
As soon as she's marked and we have urology on board, and we just finished the CTE, so within the next 24 to 48 hours.
Okay. So you take her to the operating room. Tell me about her positioning and any other preoperative workup or evaluation you'd like.
Yeah, so under general anesthesia, I would have her in a lithotomy position. I'll make sure that she's marked for an ostomy. I'll have urology place a stent on the right side, a ureteral stent on the right side. And then I'll go ahead, place appropriate laparoscopic ports. Once I gain access into the abdomen, I'll start off by mobilizing the TI, as well as the right colon and cecum. And obviously taking care, making sure not to injure the ureter, identifying the ureter as well, if I can. And then once I do that, then I'll go ahead. Once I have adequate mobilization, I'll make a mini midline laparotomy, deliver the ileocolic segment outside. At this time, I'll also manually palpate the remainder of the small intestine to make sure there's no other areas of disease. And then once I localize the disease, I'll go ahead, resect that portion, and then pull up an ostomy with an endoleostomy.
Okay, so you get in, you see severe stenosis of the TI, proximal small bowel significantly distended, but does it show any evidence of only the last 10 centimeters shows evidence of creeping fat with thickened mesentery? How do you address the mesentery in your procedure?
Hey, Dr. Merced.
Hey, how did it go?
It was good. It was good. They did good questions and they were very interesting. So it was nice. Ross, Amy, Jonathan.
Just a reminder for everybody who is not Dr. Cusick or Dr. Kandagatla to mute your mics, please.
Sorry about that. So
No.
you get into the abdomen. The last 10 centimeters are significantly dilated, and the remainder is healthy appearing. How do you address the mesentery?
So I will go ahead and resect the small bowel close to the edge of the mesentery and pull up an ostomy. I'll make sure that I oversew the edge of the mesentery to help prevent complications such as bleeding.
Okay. So you bring up her ostomy and everything goes well. You finish up her surgery and she's post-op day 1. You go and see her. Her hemoglobin beforehand was 8. She's down to 7. She's mildly tachycardic. Her heart rate's 110. Her blood pressure is 90/60.
Okay. So I'll go ahead and examine the patient. I'll do an abdominal exam. I will also, given her low hemoglobin and her symptomatic anemia, I'll go ahead and transfuse 2 units of blood for her.
Okay. You give her the 2 units of blood. You're gone back to your office to check on your clinic patients, and you get a call that she's now tachycardic into the 140s. Her blood pressure is now 80/60. She's got her 2nd unit of blood in.
Okay, so given that she's now, I'm really concerned for bleeding as a complication. So I would go talk to the patient, and I would also counsel her on what's going on and my concern for bleeding. And I would take her to the operating room to perform an exploratory laparotomy to find a source of bleeding.
All right. You get into the operating room, you open her up, you see about 600 cc's of blood, and you see a pulsatile bleeding coming from the mesentery.
Okay, so I'd go ahead, pack the abdomen and slowly take out the packs. And once I find the source of the mesentery, I'd go ahead and oversew it, if I can, with absorbable suture.
Okay. Anything else you want to do in regards to the remainder of the cut edge of the mesentery, or you're just identifying that isolated bleeder and tying it off?
No, I would go ahead and make sure that it's hemostatic. Given my concern, I would also place hemostatic agents such as Surgisil or Everest over the edge. And I would normally take this with the ligature device. So and then I would examine the edge of the mesentery. And if there's any areas of bleeding, oversew it with vicryl or absorbable suture.
Okay. She recovers well and is now post-operative. She does the remainder of her recovery without any incident. She's eating, she's drinking, and you see her back 2 weeks in the office, and she's already asking you when her ostomy is going to get closed.
Yeah, so I would explain to her that the first priority would be for her to recover from the surgery, including her nutritional status. So we'll keep making sure that she's able to intake an adequate amount of nutrition. She's able to gain some of her weight back. At the same time, we'll also talk with gastroenterology to have her get started on treatment for Crohn's disease to help prevent a future recurrence. And then typically about 6 months is how long I'd want to wait at least before. And once she meets all these parameters, then I would go ahead proceed with a take back or a ileostomy takedown.
And in doing so, do you do when do you want to restart her mesalamine, or are you going to encourage her to consider something different?
So mesalamine, she can start as soon as she's discharged, and I would also consider start biologic therapy as well, typically about 3 to 4 weeks after her surgery.
Okay. So she's fine with that. She gets in with her GI. She's very concerned about the cost of the biologics, but she says she'll do her best to get all that taken care of. Rewind to you're in the operating room the first time. All right. Yeah. So you're in the operating room the first time. You identify that the terminal ileum is densely adherent to the sigmoid colon. Didn't see it preoperatively. You looked at it. You notice that there was a fat plane there, but when you get in, reality is just quite different. It is very stuck to the rectosigmoid junction, and there you are. It's still the most distal 10 centimeters, but instead of it being freely being able to mobilize it, it's stuck to the rectosigmoid. How would you handle this?
So at this point, I'd be concerned that there may also be a focus of Crohn's disease in the sigmoid as well. While the patient is in the operating room and in lithotomy position, I'll go ahead and do a flexible sigmoidoscopy to examine that area to make sure that there's no, if it's just a fistula or if the sigmoid is kind of a bystander or if it also has active colitis.
Okay, so you're fortunate you have her in lithotomy position and you're able to put a scope in. You put the scope in and there's very, very dry mucosa. You're able to navigate up to the rectosigmoid junction. You see an acute angulation and your colon is filling up with air as you're scoping. You do not see any active full thickness Crohn's disease, any inflammation, any evidence of fistula in this area of the sigmoid colon.
Okay, so I will go ahead and try to resect or separate the terminal ileum from the rectosigmoid. And if I'm able to do so cleanly without any damage to the rectosigmoid, then that's good. If not, then I will go ahead and do a primary repair. And if there's a considerable, significant colotomy made, then I would go ahead and do a segmental resection of the rectosigmoid.
Okay, so you're able to laparoscopically kind of tease them apart. It's pretty beat up and somewhat bloody in the area, but you don't see any full thickness injury, and you don't see any evidence of a fistula or communication once you take that dissection down. Would it change how you're going to handle the rest of the procedure that you had done before?
I would, just to confirm that I did not have any injury to the rectosigmoid, I would go ahead and do an air leak test, make sure there isn't a hole that I can find. But in terms of the rest of the operation, I would still go ahead and do a endoleostomy at that point.
Okay. You were called, or you're in your office, you're seeing a 47-year-old woman who reports she's had a 6-week history of anal pain with bright red blood in her stools. She says before that, she's been totally fine, never had any abnormalities. 6 weeks ago, she came back from vacation and she's been having this intense pain with bowel movements. She says it lasts for hours after every bowel movement. She says it's bright red on the toilet paper with most bowel movements since this started. She has no history of anything similar to this. Her bowel movements are typically soft, but sometimes can be harder, especially when she's traveling or on vacation. Right now, she's actually like scared to have bowel movements. She's been missing work. She's not able to be comfortable for a couple hours afterwards. She's never had a colonoscopy. She's married. She has a child 12 years ago with a grade 2 tear that was repaired without any complications. No family history of inflammatory bowel disease or colorectal cancer.
Sorry, how old was she again? 60?
47.
47. Okay. Sorry, you said she has not had a colonoscopy before?
That's correct.
Okay, so I have most of the history that I would need. What I'm concerned about is a few things. So I would go ahead while I'm in the hospital, while in the clinic, I would go ahead and do an exam, including an anal rectal exam with, I would start off with an external exam first to see what I can find. And then depending on what she can tolerate, then I would move forward with the additional rectal exam and anoscopy if she can tolerate it.
Okay. What positioning would you have her in?
Yeah, so I'd have her in a prone jackknife position.
Okay, in prone jackknife position, she's very apprehensive to you doing any kind of exam, clenching her buttocks muscles. But you're able to do an external exam and you see a inflamed posterior skin tag.
Okay, am I able to efface the anus at all to identify a fissure possibly, or?
You attempt to do that, but you're not able to see much. You think you see kind of the very distal aspect of an anal fissure.
Okay. So at this point, I'm concerned, obviously, my is for an anal fissure, and her clinical history seems to match with that. So I would counsel her on bulking agents such as fiber or Metamucil, fiber supplements and a high fiber diet, as well as stool softeners to help her prevent constipation or hard stools, sitz baths as well. And then given that it's been 6 weeks since her symptoms started, I would also get her started on a diltiazem ointment, topical ointment, and I would see her back in 6 weeks.
Okay. Do you know the dosing of the ointment?
It's a 2% ointment, compounded, and it's to be used at least twice a day, a pea-sized amount twice a day.
Okay. So she starts using that in addition to avoiding the complication or the constipation, excuse me, drinking more water. She returns to you about 6 weeks later, and she reports that she's generally feeling better.
Okay. So if she's feeling better at this time, I would like to go ahead and do a full exam, including it with digital rectal exam as well as an endoscopy.
Okay, so you do the digital rectal exam. You feel an increased sphincter tone with some kind of spasming and quivering of the anal canal. You don't feel any palpable mass or any significant hard stool burden within the distal rectum. You're able to do an anoscopy. On anoscopy, you see a posterior anal fissure that's partially healed. It's now it's shallow. There's still a sentinel pile and an inflammatory skin tag distal.
Okay, so I would advise, I'd inform the patient that, her symptoms are getting better. Her exam also indicates that she has a fissure that is healing as well. So I would have her continue the conservative lifestyle measures in terms of the high fiber, high water, sits, bats as needed, avoiding constipation. I'd also tell her to continue using the topical diltiazem until her symptoms completely resolve. And then I would also make sure that the patient has a colonoscopy scheduled.
Okay. So 3 months later, she does a colonoscopy, nothing abnormal, all good, checks out clear. 3 months later, she comes back, same exact symptoms. She started using the ointment this time, and she's not better after using it now for 6 weeks.
Okay, so I would go ahead I'd talk to the patient, and I would go ahead with an exam under anesthesia, assuming that if I'm not able to do a proper exam in the clinic because of the same symptoms. If not, then I'd go ahead with an exam under anesthesia.
Exam under anesthesia, you see the same thing that you saw on your evaluation after she has started the diltiazem, except now the fissure is quite deep. You see the underlying sphincter muscle. There's no rolled edges or inflammatory concerns around the fissure. It is an isolated posterior midline fissure.
Yeah, at this time, I would still go ahead and take some biopsies of the fissure site, as well as some normal tissue surrounding it, and then I would see her back in clinic.
Everything comes back normal.
Everything comes back normal. Yeah. So at this point, I've talked.
Biopsies are normal. Pain's still the same.
Yeah. So
actually, pain is worse after the biopsies.
Sure. I would talk to the patient about what options she can try moving forward, including Botox injection. And if the patient is amenable for a Botox injection, the other option would be a lateral internal sphincterotomy. I'd explain to the patient that, the risks and benefits of each method, with the Botox being lower chance of incontinence, but symptoms would be temporary given the temporary nature of the Botox, with lateral internal sphincterotomy being a more effective method for preventing recurrence, but obviously a higher chance of incontinence that it would be permanent.
Just a 2-minute warning.
Okay, so she says, you fix me once, fix me again.
Okay, so
I'll do what you tell me to.
Sorry, what was it?
She said, you fixed me once with this fissure. I trust you. I'll do whatever you tell me to.
Okay, so in that case, I would go ahead with a Botox injection. So exam under anesthesia with the Botox injection. Walk
me through how you do that.
Yeah, so I'd have the patient in prone jackknife position. Once I do that, once I have the retractor in the anus and expose the sphincter, as well as the fissure, I would draw up 100 units of Botox into 1 cc of normal saline, and I would inject 50 units on either side of the fissure directly into the internal sphincter muscle.
You're back in your office after you've done your anal rectal cases for the day, and you get a call from her husband that she has pooped all over his car.
Okay, so I would have the patient see me in clinic as soon as she can. I've talked to the patient on the phone as well, make sure there's no other issues, concerns, but if she can wait till the clinic, I'd have her see me in clinic, and I would explain to her that, this is a very likely side effect, not very likely, but this is very likely to be secondary from her Botox injection. So I would have her start her on high dose extra fiber bulking agents, as well as antidiarrheal agents such as Imodium, to see if that can improve her symptoms.
Okay. I think I'll stop there because I think we're pretty close to time. Are we doing an evaluation now or at the conclusion?
Yes, we'll do a couple minutes now if you would be so kind as to give feedback, and then at the end we'll just wrap up with closing thoughts.
Yeah, so I thought you handled both scenarios very well. So you stayed calm, you were focused, you had good eye contact throughout the entirety of the examination. I think that you knew a plan, but weren't like too far in the weeds to be able to see a curveball coming. A couple of things that I would say from the Crohn's disease case. Number one was, I know I harp on my fellows, don't ever present to me a Crohn's disease without looking at their bottom, right? Because it can give you a little bit of insight if they're gonna have fistulizing disease. And I see some of my former fellows on here, and they'll vouch to that. And I know you probably, would have done that, but you didn't say it, and I didn't give it to you either, right? Like you said exam, I didn't give it to you. And again, I know you would have done it, but I don't know you were going to do it unless you said it.
Right.
Other things that I kind of gave you all the pretext of having a nutritionally deplete patient, but there's probably a little bit more lab work that you could have done, right, to confirm that, to really help solidify your decision of making an ileostomy, right? So you got I think I gave you an albumin one time, which was 2.4. I know you had the 15-pound weight loss and all this, and I don't disagree with you, but if just you could have gotten a little bit more information in regards to her amount of nutrition or her nutritional status and evaluation to make a determination for ileostomy. And I think that's the right thing. That's a safe thing, right? It could have gone either way. You could have done ileocolic resection if, what if you got her pre-albumin up to 20 during the week or whatever that she was getting TPN? Would that have changed your mind of doing an anastomosis? Maybe not, right? So I do think lithotomy was good. I don't know if the CT enterography really added anything because it's an obstructed patient, right? And so that's pretty tough exam to do on a patient. I mean, I'm not going to fault you for doing that. Did it change your management?
No. Right? I think it's sort of my usually go-to for, I guess it's better for patients that have had previous surgical resections or multifocal or a concern for multifocal. I guess in this patient, I think it was an unnecessary test.
Yeah, and I don't think I'm not going to fault you for it. There's no like critical fail associated with doing that test, but I don't really know if it added anything. The one thing in regards to management of Crohn's disease, make sure that if somebody, like I obviously gave you the mesenteric bleeder because you took the bowel right at the mesentery and bowel junction, and I told you that mesentery is very thickened. Right. So if you're going right there at the bowel mesentery junction and you're using a ligature or whatever, that's high risk for bleeding there. Right. So you may want to just a little clause of what you would probably do in the operating room, try to transect the mesentery where it's soft, pliable, where you can confirm good hemostatic control. So that was the Crohn's case. In regards to the anal fissure case, I didn't have any concerns, didn't have any reservations. I think the sooner you said, what's her age? Has she ever had a colonoscopy? Just go ahead and blurt it out then. Like, patient needs a colonoscopy, because they may take you around to abscesses and fistulas and all that kind of stuff. But once you said it, like examiner, like there's a checkbox. Okay, colonoscopy, and then you're done with that. And I know you were thinking it. It was just, you said it at an appropriate time, which is fine. And I agree with you. Maybe you wouldn't do a colonoscopy, right away at your initial anal evaluation. But if you set it, then you've got it marked off, and you're not going to get distracted from that later.
Yeah, that's a good point. Yeah. Perfect.
That's the only evaluation or suggestions I had. Good job.
Thank you.
We do have a question in the comments from somebody who's viewing. Would you bring up a lateral internal sphincterotomy in a woman with a prior episiotomy?
Yeah, that's kind of where I was going with the incontinence episodes kind of afterwards. And if there would have been a choice for doing a lateral internal sphincterotomy, yes, you have to know the number that you're going to quote a patient, have it ready for the examiners of what you're going to say, and have it be backed up by data on what are you going to quote them as their incontinence. I did give you the information that she'd had a repair, but that she'd had no evidence of fecal incontinence in the past. Yes, you be expected for that when you have a fissure case, especially in a, not a young woman, but a woman that's had children vaginal deliveries in the past. Be ready to answer that question and how you're going to manage it. And if they don't give you the information, ask.
That's exactly what I was going to say. They may not give you that obstetric history. You have to ask it. Dr. Susan was nice because when you listed off the dose of diltiazem, I was like, okay, where's the question? As patient calls back, has a headache, wants nifedipine. All right, they will ask you that on a fissure question. No, diltiazem, nifedipine, nitro, all the strengths ready to go because they will ask you. They will be that specific. The only comment I had on the Crohn's, when you're for the right colon, you're doing the other colic resection, you said ureter, also duodenum. They will get you with that duo, because right ureter, yeah, it's good to think about it, but really you're not on the left side where the left ureter is much higher risk. On the right side, it's the duo, and especially Dr. Suggs is telling you that the mesentery is involved. You may have to go down. Soft mesentery right might be at your ileocolic takeoff, so you have to be wary. Pat the duodenum down. Be on the lookout for it. You have to mention it because
good point.
if
Thank
you were
for bringing that up.
Yeah, if you were practicing with me, I would have been like, okay, post-op day 2, let's say you left the drain in, now it turns green because you dinged the duo or something. Yeah. I would have tossed it back to you because that's honestly the best way to practice for this is what we're doing right now with a group of co-fellows, buddies, to just go over scenarios. And we would do it to try to mess each other up a little bit. Okay, because you never know what they'll ask you. You never know. But other than that, I thought you did very well. Just when you get thrown a curveball, breathe a second, because sometimes you would go right into it and you would kind of fumble on your words a little bit. Take a breath. It's okay. You have a lot more time than you think. You can take a 5-second breather.
All right.
Right.
Excellent.
Well, thank you so much for your time and the feedback.
Great. And so with that, we'll transition. Thank you, Dr. Cusick and Dr. Kandagatla. We really appreciate your participation. Next up, we'll have Dr. Calafel, who completed his undergraduate education at FIU and his medical school at Ross University. He completed general surgery residency at the University of Connecticut and colorectal fellowship at Lehigh Valley. He's currently on faculty at Baptist Health of South Florida and will be administering an exam to Dr. King. So take it away.
All right. Let's see, I don't see him yet.
He was on earlier. Let me try to message him again.
Did he get scared? Did we scare him?
While we're waiting for him to join back, I think it's just important to give a couple of pointers from when I like to practice with my graduates and my fellows. Number one, they're not going to try to give you something that is just you've never heard of, right? They're going to give you something that you've probably seen and it's just kind of masked into because of something else. So Do your evaluation like you will do it when you see that patient, turning it into a patient that you've seen and taking care of them like a patient you've already taken care of. And then also, turn it into an operation that you feel safe with, dictating into, your operative dictation. Just talk through that step by step like you would if you're, taking a trauma patient back to the operating room. And how are you going to do it systematically and thoroughly, and making sure you identify the right pathology. And then if you do forget something, it's okay. You have that entire time during that question block to answer the question. So if you say, you know what, I was totally off. I didn't mean that I was going to give them alprazolam, compounded ointment. I meant diltiazem, and that's what I meant. Just whatever, and just say, you know what, that's what I meant. I just kind of got lost in those words, but diltiazem, yep, that's what I meant, and this is the dose. And so just take that opportunity to correct yourself and to kind of take that breather, like Dr. Calfell was saying, take that breather and just kind of get yourself back together and answer the questions.
I think alprazolam ointment would be awesome for some patients. Let me tell you that. It's like, shh, quiet now.
Dr. King is having some technical difficulties. He's on vacation in a rural area right now.
So actually, thankfully, Dr. Kandagatla has offered to suffer through yet another exam for all of our benefit. Thank you
If
very
someone else
much.
wants to go, if someone else wants to step up, I mean, but if he wants to, hey, good.
Or if
good
somebody
practice
else
for you,
would.
my friend.
Yeah.
All right. So I'll get you started. Let me see to make sure that I'm looking right at him. All right. Are you ready?
Yeah, let's do it.
Okay. All right. Take a breath. I say this to every time I do practices with everybody. We're two colleagues having a discussion in the surgeon's lounge after a nice day of surgery. You got a cup of coffee. I got a cup of coffee. All right. So you have a 55-year-old male that the emergency room gives you a call about. States patient comes in with a 2-day history of abdominal pain, bloating, and just distended. Is not feeling well. Right now, vital signs are stable. They're pending a CT scan, but they want to just give you a heads up just because they're a little concerned about this patient.
Okay, so I will go ahead and see the patient, talk to the patient, get a history in terms of prior history of similar symptoms, prior history of colonoscopies, prior history of surgeries, as well as prior history of personal history of malignancies or family history of malignancies, as well as other symptoms such as weight loss or bleeding per rectum that they may have experienced in the past few months.
So he tells you that he's noticed some not bleeding, but kind of like dark colored stools for the last like 6 months. Weight loss, hasn't really noticed much. He's a guy that doesn't really take care of himself. Never really goes to doctors, no medications. Has told you he's had a belly button hernia surgery before when he was a kid. No history of colonoscopy. Says dad passed away of what he thinks was colon cancer in his 60s, but really not too sure of anything else. No smoking history, no other pertinent history to your exam. Okay. So what else would you want to do with the patient?
So to also get vitals on the patient, as well as move forward with the physical exam, including an abdominal exam, as well as a distal rectal exam.
Okay. So vital signs are stable. You just notice that he just doesn't feel well. On exam, he's distended. He is tympanic. He is tender on the left side of the abdomen, kind of mid-abdomen. Not guarding, not rebounding, not peritonic, but he's tender. Okay, digital rectal exam, you don't notice any change, and you see no blood on exam.
Okay, so I'll go ahead and move forward with ordering some labs, including a CBC, a BMP, a lactate, as well as an albumin, pre-albumin. And yeah, I'll start with those labs for now.
Those are already cooking by the ED. They did that, and the ED nurse actually tells you, "Hey, doctor, the CT scan is back," and I'm going to show it to you now because I love pictures. So
excellent.
All right, can you see my screen?
No.
Okay.
Oh wait, it's starting.
Nope.
Yep, there we go.
All right. That's one slice of the CT scan. And that is his colon.
Okay.
All right. Now what?
Okay. So moving forward, so I'd have the patient make sure the patient has adequate IV access, as well as an NG tube in place for decompression. I'll take a look at the CT to see if the small bowel is dilated or not. Will give me an idea of whether the has a competent ileocecal valve.
Not really. The small bowels appears normal. You see some thickening and it's kind of maybe a bulkiness that looks up like a possible mass in the descending colon.
In the descending colon. So at this point, I'm obviously concerned for a large bowel obstruction secondary to either a colon mass or malignancy of some sort or a diverticular stricture. He has not had any endoscopic workup in the past. Given the dilation, the degree of dilation that he has in the on the CT, as well as the tenderness on exam, I would like to have the patient be taken to the operating room once he's adequately resuscitated. And I'll go ahead and take a look at this mass to see if it's resectable, easily resectable or not.
Okay. Are you going to talk to him about, what type of surgery, a potential ostomy? Because he's kind of freaking out about an ostomy. He says, hey, one of my buddies had an ostomy and I'll never want to live through that ever again.
Yeah, and that's completely understandable. So I would talk to the patient and tell him that he's definitely going to end up with an ostomy when I take him to the operating room. The type of ostomy he has will most likely be determined by what I find in the operating room. If I'm able to resect the mass or the site of obstruction, then he will end up with an end colostomy. If there's any other concerning findings, such as metastatic disease, or if I'm not able to resect it safely, then I would give him most likely a loop colostomy. At the same time, if I'm concerned that his cecum is damaged or threatened, then he may end up with an endoleostomy at that point.
Okay. So you're going to the operating room. Describe to me his positioning and how you have the room set up.
Yeah, so I'd have the patient in a lithotomy position, and given the distension of his colon, I'll go ahead and do an midline laparotomy, and then and once I'm in the belly, I would go ahead palpate the colon all the way to the level of the obstruction to see what I'm able to spot. I'd also take a look at the liver as well as the pelvis and the peritoneum to make sure there's no evidence of metastatic disease.
All right. So you go in and, you see dilated colon, the transverse colon looks healthy and was just dilated. You go to the descending colon, you feel this very hard, rock hard mass, pretty adherent to the lateral abdominal wall, but you're able to get it freed. And you notice, you take a look around the liver and the pelvis. You notice on the left lobe there, you feel something hard. Wasn't seen on the CT scan, but you feel like a 2-centimeter nodule that feels hard. And then you go around the back of the dome of the liver, you feel a couple more small spots as well.
Okay, and am I able to, if I can, I would go ahead and biopsy that nodule with a core biopsy.
Okay, you can send it off, but this is 9 o'clock at night. Pathology is not in-house.
Sure. So I'll still go ahead and send it for routine rather than frozen. But given the suspicion for metastatic disease, I mean, if I'm able to resect the mass, I would still go ahead and resect the sigmoid and give him an end colostomy at that time. And if I'm not, then I would do a loop colostomy with the transverse colon.
Well, you're the surgeon, doctor. What do you want to do?
So you said that I was able to tease it off of the abdominal wall.
Yep.
And if I'm able to, identify the IMA pedicle, and this is in the sigmoid, correct? I just want to clarify.
The descending colon. This is like mid-descending colon.
So mid-descending colon. So yeah, the mid-descending colon, I'll make sure I can isolate the IMA pedicle, and I'll go ahead and do a resection. I'll also talk to anesthesia, make sure the patient is stable and that he can tolerate that resection. And I'll go ahead and do an end colostomy. I'll make sure that I identify the left ureter so that it is not injured in any way.
Okay, so you're able to get through that. You do your biopsy, you take the mass out, you bring up an end colostomy, you close him up. He does well. Post-operative day 3, your PA or your resident gives you a call and says, hey, this guy, the ostomy's really not opening up, and now he's really tender in the right lower quadrant. You do a CBC for you, and the white count is 25.
Okay, so obviously my concern is for a cecal perforation or ischemia of the cecum in the right lower quadrant, given his question. So
I want to take you back to the original OR. Would you want to do one other thing or look at something else while you were in there?
yeah, sorry if I thought I mentioned it, but I did not. But I would definitely make sure and examine the cecum to look at the integrity of the cecum.
So you do that, and the cecum looks like this.
Yeah, to me that the cecum looks dusky, and there seems to be some serosal injuries as well. So I will go ahead and do an ileocolic resection at that point as well. And I would.
Ileocolic. So you're gonna do an anastomosis on this guy?
Oh no, an ileocolic resection with an endoleostomy.
Remember, you're back in the original OR. You're back in the first case. I brought you back to the operating room to check out that cecum one more time.
Okay, so I'm in the original case, so I
Mhm.
haven't resected his left colon yet.
Yep.
So I would then do given his obstructive nature of the case, I would at that point do an resect his cecum, terminal ileum, and then give him an endoleostomy with the mucus fistula.
Okay. All right. All right, good. That's not and now let's say that left lobe issue. Let's say the left colon's completely clear. I mean the left liver and the right side of the liver, the whole liver is clear. There's no signs of metastatic disease.
So if there's no signs of metastatic disease, then I would go ahead do a resection of the left colon, give him a left end colostomy, and then do an ileocolic resection, and I would go ahead do an anastomosis at that point.
So anastomosis, the
With
end
an
colostomy.
colostomy.
Okay, all right. If I were to tell you his albumin coming into the surgery was 1.8, would that change your mind?
Yes, it definitely would be. I would so at that point, I would go ahead, do the resection on the left. Or, I mean, given his, low albumin and everything like that, I think I would just stick with doing an ileocolic resection with an endoleostomy and a mucus fistula. And then I would plan on doing a definitive operation when he's more optimized.
Okay. All right. Okay. All right. That was pretty good. Okay. When he's out of the operating room, is there any other imaging or any work that you need to finish up for him?
Yeah, given my concern for malignancy, I would go ahead stage him with a CT abdomen pelvis, which is already done. So I'd do a CT chest as well as a CEA.
Okay. And he tells you he's really upset that you told him that you left the cancer in.
Yeah, I mean, I would counsel him. I would talk to him and say, I tried my best to not leave it in, but at the same time, I was concerned about his cecum as well as the complication from his malnourishment, and so right now I wanted to temporize him and avoid abdominal sepsis from a colon perforation, and the goal would be in the short term to go back and resect the cancer, or
Okay.
depending on yeah.
He was reading something online about a subtotal colectomy. Would that have been an option?
That would have been an option, yes.
Okay. All right. All right, we'll stop there. Okay. All right. And then I saw Dr. Kang is back.
Yes,
Hey.
Dr. King has joined us and is ready for the final scenario to give Dr. Kanagawa a break.
I know, poor guy. I'm sorry.
Hey, I'm sorry about that. I lost track of time.
No, it's all right, buddy.
Running around. I
Don't-
apologize.
Don't do that on the real exam. All right.
Yeah.
Okay. All right. So let's see. So second scenario for you, my friend, you have a 47-year-old female that comes into the hospital. You've seen her a couple of times before. She's been admitted for diverticulitis in the past, has been treated by her partners non-operatively for non-complicated cases of diverticulitis in the sigmoid colon, never really followed up. And now she presents to the emergency room again with a CT scan showing moderate inflammation to the mid-sigmoid colon, no signs of microperforation, no abscesses, no phlegmon. White count is 16. The rest of her labs are normal. She doesn't really have any medical history that's pertinent. Her family history is all negative, but she's never had a colonoscopy before and no surgical history.
Okay, I would go to the emergency room and examine the patient, make sure I would focus on the vitals and also do a abdominal exam.
Okay, so abdominal exam, she's mildly tender in the left lower quadrant. Not rebounding, not peritonitic at all. Vital signs are stable. She's slightly tachycardic, 105, 106, but she tells you she hasn't really eaten or drank anything all day. So how would you proceed?
All right, at this time, I think you said the white count was 16,000, but otherwise normal. I would,
Yep.
given her tenderness, I would make her MPO. I would start her on IV fluids and IV antibiotics and review the scan myself. I would, at this time, plan to manage her non-operatively and and just do serial abdominal exams and serial labs.
Okay, good. I didn't hear the diet. What diet would you give her for now?
For right now, I would just do MPO with maybe sips of clears and make sure that I do serial abdominal exams, make sure it doesn't get worse.
Okay. You do that for about 24 hours. You reevaluate her. She feels about the same. Not really better, not really worse. Eventually, hospital day 3, her white count normalizes. She gets a little bit better to a point where she can tolerate some full liquids, but is not pain free. Anything you would change?
So at this time, and her, you said her white count has normalized and her vitals have remained normal.
Mhm.
I think at this time it'd be reasonable to, as long as she's stable, educate her on a full liquid diet and discharge her on full liquid diet, as long as, again, her abdominal exam has improved. However, if I have any concerns on my physical examination, I would plan to re-image her with a CAT scan.
Okay, her physical exam is better than what you see her. She's really eager to go home. Let's say you send her home, what antibiotics would you give her?
I would give her something to cover gram negatives and anaerobes, so either Augmentin or third generation oral cephalosporin.
What do you want to send her
flagyl.
home with?
I
What
would
do
just
you
do
want to send her
I would
home
just do
with?
Augmentin.
For how long? And the dose?
I would do Augmentin for I would do it for about 10 days, and I would just do the BID dosing. I believe it's either 825 or 875. Can't quite remember.
He's asking you for a number. You're the one writing the script.
Yeah, I should know, but I do not remember.
Okay, so you give her the 875 of Augmentin, BID for 10 days. She finishes the antibiotics and she calls your office and says, I'm having the pain all over again. I feel the exact same way as I did last time. I'm heading to the ED. You meet her there. CT scan shows the same thing. Moderate to mild inflammation of the mid-sigmoid colon, just not getting better.
Okay. So ideally, I would have wanted to do a colonoscopy on her about 6 to 8 weeks from this operation. However, just based on her clinical presentation, and I would diagnose her with smoldering diverticulitis. I would advise her that, again, she has failed non-operative management with just a conservative management. So I would discuss the risks and benefits with her and consent her for sigmoid colectomy. But before then, I would make sure that I have nutrition labs and assess whether or not she's been losing any weight.
No weight loss. Her albumin is 4.1. Her pre-albumin is 16.
Okay.
Okay.
Yep. Go ahead.
All right. So when you said sigmoid colectomy, she's really freaking out about a potential ostomy bag. Are you talking about an ostomy for her?
Yeah. So with her, I would discuss with her that given her normal nutrition labs and on imaging, she's had this smoldering diverticulitis. There's always a possibility of an ostomy with any kind of a bowel resection. But in her case, again, with normal labs and no weight loss and high suspicions for smoldering diverticulitis, I would proceed with a minimally invasive sigmoid colectomy with primary anastomosis.
How would you describe that and how would you prepare her for surgery?
Actually, I'm sorry, I'm going to have to backtrack. Unfortunately, because I cannot prep her colon, I don't, Yeah, so I don't think she'd be able to tell. So she's coming in not with unprepped colon, and I would discuss with her that if I have any concerns that she would end up with an end colostomy, but that I would have plans to reverse her down the road.
Okay. I mean, it's only been a week and a half since she left the hospital last time. She's saying, like, is there anything stronger antibiotics that I can try to avoid surgery at this time? Like, doctor, I would really love surgery, but I don't want an ostomy bag. I want to get through this.
So we could trial ciproflagyl, but she has been seen by my partners in the past. She was on IV antibiotics for multiple hospitalizations, and I would discuss that. Yeah, I would love to get you through this and get a full colonoscopy on you. But given that you have failed again multiple medical managements of this disease process, I think getting the sigmoid disease part of the colon now would be the best step forward.
Okay. She's stable right now, and she says she's willing to drink anything. Like, she was on full liquids, just a couple of days ago.
Okay, well, in that case, then I would keep her on IV antibiotics and prep her bowel with plans for primary resection with primary anastomosis.
All right, so she's actually able to take the bowel prep. She's feeling a little bit better, but still tender, and she agrees to surgery. So how would you set her up for surgery?
So in my hands, I would do this robotically. I would place her in lithotomy with both arms tucked with orgastric tube under general anesthesia. I would place my robotic ports 8 millimeters from the Palmer's point, the left upper quadrant down to the right ASCRS. I would place my stapler port in the right lower quadrant.
You're already in the belly, okay?
Yep.
So you get in there. No, that's right. You get in there and you see the mid-sigmoid colon is pretty inflamed. It doesn't feel like a cancer or anything. It looks like diverticulitis, but the rest of the sigmoid just looks really inflamed and really beat up.
Okay. So I would fully mobilize the sigmoid colon, taking care not to injure the left gonadals or the left ureter. And I would resect distally at the rectus.
How would you identify the left ureter, Dr. Kang? Where in your dissection? Where are you going to be? I want to know your steps of surgery to get to the point where you're identifying the left ureter.
Okay, so I would initially start with the medial to lateral dissection at the sacropromontory, and I would lift up the superior rectal artery and push down on the separate out the retroperitoneum and identify the ureter that way. If I can't go that way, then the ureter can also be identified at the bifurcation of the external and internal iliac arteries.
You're trying to look, it's just there's a lot of inflammation. You really can't see the ureter very well.
Okay, so if medial to lateral doesn't work, then I would go lateral to medial.
Not great. It actually looks worse. The inflammation on the lateral side is worse.
Okay. Then I would start with the infra-IMB dissection and see if I find a more normal plane and track it down that way.
This is a 2-minute warning.
You kind of see something that looks like the ureter, but you're still not 100% for sure.
All right. Then in that case, I would be concerned that given her chronic nature of diverticulitis, that the ureter may be pulled medially, and I would not feel comfortable just going through the mesentery like that. So I would ask my urology colleagues and come in and to see if they can place a stent. If they're not available, then yeah, that's what I would do. I would see if urology can come in and place stents.
Sure, actually, your friendly urologist is actually right next in the next room doing a case. He comes right in and throws in a right and a left stent for you, no problem. And with that, you're able to identify the ureter very well. You're able to move it away. You're able to take your IMA and you do. Now, let's say you've done your IMA and you have this big inflamed piece of sigmoid colon. So now what is the next step? Are you going to resect and give her an ostomy, or are you going to potentially try to put back together?
So if there's no gross perforation or gross infection that would preclude from my anastomosis, I would resect distally at the rectosigmoid junction. I would extracorporealize the colon, feel proximally to see which part of the colon feels healthy, and resect there. And I would do a primary anastomosis and do a leak test at the end.
Okay. All right, you do a leak test. You know, patient does well. I'm gonna take you back to when you first see the when you're inside the abdomen. You notice that the sigmoid colon, the part that's really inflamed, just one portion of it is stuck to the bladder, and you're dissecting it. You notice it's a colovesical fistula. So you take that down, and how would that change your surgery at all?
Yeah, so can I identify the hole in the bladder where I took it down?
Yeah, you see the bladder. It's at the dome of the bladder. You know, you see there's a little bit of hole in the bladder. It's pretty beat up and inflamed.
Okay, so I would do I would backfill the bladder, see exactly where I can see the hole. I would primarily repair that with 2O vicryl observable suture, and I would leave the Foley in for 10 days and do a cystogram before pulling the Foley.
How many layers is that closure going to be?
I mean, I could try 2-layer, but in cases like this where things are so inflamed and fistulized, I think 1-layer repair may be sufficient, and I could mobilize a piece of omentum and throw it down there as well to try to buttress the repair.
All right, good. All right, I'll end the torture. Good job.
I don't know about that, but thank you.
Yeah, no, I'll be honest. I'm mean with these exams because I don't. They can be pretty mean to you. So let me do the first comment to Dr. Gatla.
Yeah, please. Thank you.
So first, how do you think you did? I always like to ask that.
Well,
because most of the time you are your worst enemy.
Yeah, absolutely.
And
I
your worst
think,
critic.
obviously I messed up on the last part, definitely with the subtotal. It didn't come to my mind in terms of like, that's the option to go to. And, leaving cancer and obviously never a good thing. But that's, yeah, I should have thought of that. I think
your answer choice is not bad with the liver being positive. I'm always of the mindset, man, I really want it. If it's that cancer is mobile and you can take it out, take it out.
Right.
Your answer would have been good if I told you, listen, that left colon cancer is stuck to everything. You can't get it out. You're leaving pieces of it behind. Then yes, absolutely. But I would, the subtotal colectomy is definitely a good option. And also with the subtotal colectomy, if the small bowel's not dilated, you have clean margins, everything looks good, you can put it back together.
Sure.
Because it's small bowel. It's an ileosigmoid resection. It's an ileorectal. It's an ileosigmoid anastomosis, an ileorectal anastomosis, and you could avoid an ostomy in that patient. Your workup, you worked him up very well. You went stepwise. I gave you the history, but you went through everything because I didn't give you much. I said he just showed up to the ED because that's what's going to happen. Okay. You identified on the CT that the cecum is very dilated. The key thing is you mentioned it before surgery, but in surgery, you said nothing about checking out the right colon. Always check the whole colon. And I was mean. I even told you the transverse colon looks fine. Okay. Transverse colon always looks fine. It's the cecum that's going to get you. And you identified on that picture, that's actually a real intraoperative picture. That's actually one of my cases. And you notice that there's it doesn't look that bad, but when you really look at that picture, there's some dusky portions and you notice the big serosal tear right along the anterior portion. So actually that case I gave you is similar to a case I had. It was a female. I gave her an ileosigmoid anastomosis. She actually did pretty well. And thankfully the cancer was only a stage 2, but it was a big, just bulky mass. But no, that was the key thing. Remember, subtotal colectomy is an option, and it's a very viable option for a case like that. But other than that, and then after the procedure, you got to finish your metastatic workup because that's something happens. Like you rush the guy to the OR and you forget CT the chest, CEA, all that stuff. You got to get it. What else? I'm glad that you saw with that CT scan, you said, I'm going to the OR. Because then what happens is I give you the patient the patient calls you in the middle of the night, now is having severe right lower quadrant pain. Because now the cecum is probably perfed. Okay. But good job. Other than that, very good job. Okay.
Thank you. Thank you.
And somebody put Justice Philip. Oh, I saw his question and it was a good question. So I'm trying to do an ileorectal and with the patient. You do have good concern. He did do a digital rectal exam. The CT scan didn't look too bad. You can always throw a quick flexig up there to the rectum to check it out. Definitely it's something to talk about. And definitely during my case, I did the same thing. All right. All right. But the key principle with that one is remember your options for a subtotal colectomy. Dr. Kang, how do you think you did?
It went okay. I just kind of panicked because I'm like, man, I totally just kind of lost track of time. I'm like hopping on and
Yeah.
I don't know.
No, it's okay. You're rushed in a situation, but sometimes that happens, man. You get caught up. Your situation, your stress level is relatable to. It's like, man, you're thinking about the last question. Man, I really messed up that last question, and that brings you down the rest of the exam. And it's okay. You can get a question wrong. You can get beat up. You can not, I don't want to say bomb a question, but you can do poorly on one question and still pass the rest of the exam. Okay. Remember, passing is not 15 out of 15. It's not. So think about that. Just don't get discouraged. Move on. You gotta have very short-term amnesia. You gotta forget about the last question and keep going, because that last question is gone. You can't, if it's in another room or another examiner, you can't do anything about it. So, see the patient, work them up every single way. Vital signs, exam, you did well. One thing I would say for you is, in terms of style, maintain your eye contact. There were some times where you kind of visioned off and moved away from the screen. You can tell you visibly got frustrated when I was trying to poke and prod you a little bit, and especially also interrupt you. And they will interrupt you too. Like when you start talking about putting your ports in for your robotic sigmoidectomy, they're going to get you to move on. They know you know how to put in trocars. This isn't the general surgery boards. I'm not examining a second or third year resident. I know you know how to put trocars in. And I know what your trocar position is going to be. I want to know, listen, this is what you see in the operating room. What do you want to do? And you immediately jumped, okay, I'll do the left ureter. And that's where I kind of wanted to get you. I wanted to see all your steps of identifying a left ureter on a very badly inflamed sigmoid. Okay. If I see a nasty sigmoid like that, even if the patient got prepped, I'm leaning towards the Hartmans, truth be told. But putting back together is not a bad option, especially you have very good margins. The patient tolerated the prep well, and the prep was good. The colovesical fistula, you did a good job. I was trying to get you to throw in like Proline or something, which is a no-no with bladder repairs. 2-layer is always optional. Good job leaving the Foley and do a cystogram 7 to 10 days later. That's good. Don't go crazy about jumping into partial cystectomies and things like that, because that is only an option when you are concerned about cancer. Granted, I didn't give you a scope patient. You could mention, I would send the specimen off for frozen to make sure this is diverticulitis and not cancer. That's an option I would throw in, because this is an unscoped patient. You don't know 100% certain this is diverticulitis. Okay. All right. So other than that, I thought you did okay, but just a couple things to work on, just style wise. You got through it, but style points are very key to just navigating yourself through the scenario, and also saves you a lot of time.
All
I
right,
agree.
sounds good.
Yeah, Dr. King, I would say that your stress level is probably very similar to what it will be on the day of exam, right? Like it's just heightened awareness and stress level. So just process all the information, and it's okay to have a short pause before answering the question. Don't feel like you have to jump in the first, thing that comes to your mind. You can definitely use appropriate stalling techniques. I would consider blah, 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 but my choice ideally would be X, Y, and Z. So that kind of allows you to be thinking out loud a bit, as opposed to just saying the one thing that you think, but also going kind of through some other options, which if you go down a rabbit hole, kind of lets the examiner bring you back and say, well, okay, okay, so he's thinking about these options, but obviously he's chosen option A, so let's bring him back to maybe consider option B or C. So a little bit of, external or expression of what you're thinking can help, instead of going down a rabbit hole and then kind of being too definitive and secure with your answer. Being able to pivot, I call it.
Yeah, and it's always great to give options, but remember, at the end of the day, they're going to ask you, and they will, what do you want to do? Okay. And I do it to my med students, and these are med students all the time, because I'm trying to prep them, because, that's what's going to happen. It's going to be, okay, I can do this, I can do this, I can do this. It's like, listen, I can go shopping at Costco one day and BJ's the next day. You have to make a choice. What do you want to do, surgeon? And that's where I want to kind of push you. And same thing, when you're going to give a medical treatment with, I really would I tricked you on the antibiotics. I know that's like step 1 level type of stuff. They will ask you that. On my oral board, I had a smoldering diverticulitis. They asked me whatever antibiotic I was going to give. They wanted the dose and the regimen, the days, everything. Okay,
All right.
so if you didn't, that's something to brush up on, because we give these antibiotics all the time, and it's very easy to forget what the dosages are. Man, this could be a little, 50-bed hospital that you're the only surgeon there. There's no PAs, there's no residents. You're filling out everything. So you have to know that stuff. They will catch you on that. And just knowing that bit of information, man, that's a check mark. That's a point.
Yeah, thank you.
No problem. Okay. It's just something to like quick list, quick hit, like, a day, a couple days before the exam.
Awesome.
All right.
Thank you guys very, very much. This has been excellent. Any closing or final thoughts from either of our examiners? I know that was a lot of really good food for thought.
Jillian had a thing, decompressing the cecum and reevaluating improved perfusion. To me, if it's dusky, it's dusky. When it's been obstructed for that long, especially a big serosal tear like that, I don't trust that cecum. Because what happens is that, I continue on with the scenario, post-op day 3, post-op 2, that cecum perfs. And now you're in big trouble. And then, yeah, would you consider ileocystectomy and endoileostomy with a mucus fistula? I would, if it was the type of cancer that we described before, big, bulky mass, could not get out, it like just stuck. But if you can get the cancer out, typical rule of thumb is get it out.
All right. Well, thank you guys. Thank you for your time. We really appreciate it, and for humoring all of our questions. And thanks to our examinees for letting us publicly torture you a little bit for everyone's benefit.
This is the best practice you can get. Okay. I mean, like, kudos to you guys. Okay. It's really, it takes a lot of courage and, confidence to just come on here and just be examined, in front of, everybody. Okay. And this is live and recorded, so people can see it again and again. Okay.
Awesome. All right, everybody. Don't forget to go to our website, CRS Virtual Education, and sign up to our listserv to get notifications about future recordings like this one. Thanks, everybody, and have a good night. Thank you.
Thank you.
Thank you. Good luck, guys.
Thank you so much for your time.
Great luck, guys, to whoever's taking it. And for the next year applicants, this is how you do it. Start practicing Zoom, over the phone. This is how you crush this exam. It really is. All right. Good luck to all of you.